Hello dear stagers in Group D in Faculty of Medicine, Jaber Ben Hamad Medical University. Welcome to this series of sessions about slides and different issues related to the course of pediatrics for stagers. I will present this to you by the e-teaching process, and I hope it will be useful for you. But firstly, I hope you and your families are in good health and you are following the instructions of protection from coronavirus infection, and you are strictly adherent to your home to apply the curfew for the benefit of all. As I say, this is the first session of neonatology slides, as you see here. And before I go into the details, I have to inform you that because of the different way of presentation from that happened in the lecture hall, and it was absolutely interactive between me and the students, so few notes can be repeated here and can be concentrated on. That is, you have to know how to answer the slide questions. You know, the slides is a fixed and important station in your examination, NOSCI examination. So it's important to know how you will answer it. That is related to neonatology or other topics of the pediatrics. Firstly, the slide is could be a picture. Could be an X-ray or other radiological investigation or result of lab investigation. So you have to analyze the picture, analyze the slide, and prescribe the slide, and then you will go to the question that is related. The questions here could be direct question. This is for the what's called the spot diagnosis slides. Could be just a pathognomonic or diagnostic finding in the picture and need no more words or notes to explain it. Or the slide may be coming with short notes, a short history to aid you, to help you how to answer. And the question itself could be different. Sometimes the question is directly related to the slide, or sometimes the question is of a secondary type. That's mean you have to know the slide, then you have to answer something related to it. I will give you an example. If the slide about measles, patient with measles, the question could be, what is the complication of this condition? So first you have to know this is measles, then you have to know the complications of the measles and to answer it accordingly. So when the answer is this is measles, your answer here is not correct, and you will not take a mark for this question because the question is indirect. But in cases of I give you a radiological finding and ask you what is this finding, like if I give you a double bubble shadow that happened in duodenal atresia, so you have to answer this is a double bubble shadow due to duodenal atresia, and that's it. So this is the examples of the different types of questions in slides. But in this session, because we are talking about the neonatology slide, and this according to its title, this is a first group, so I will start with the questions and I will comment on each picture, and I hope you get the benefit from this way of presentation. As I said, here we go. So this is the first slide. As we said, we have to prescribe or describe the picture. What we see here, this is of course a neonate, a newborn. What is the thing that make us think there is abnormality in this picture or in this slide? Of course, if you notice here, these two lines of redness. these two lines of redness that found on both cheeks of the neonate. So what it could be when I find this? This is called erythema and abrasion. Erythema and abrasion is one of the soft tissue injuries that happened in the deliveries. Which type of deliveries? From its picture, from its shape, it's mainly due to forceps application. And the question may be, what is the course of these, or what is the nature of or pattern of this injury? We have to say that most of them are self-limited and do not require treatment unless the complications occur. So this is a soft tissue injury, one of the types of birth injuries, presented as erythema and abrasion, these two red lines on the cheek, and this is due to forceps application. Going to the next slide. What we can see here, this again a newborn, so something related to newborn. What's abnormality? If you notice here, these spot-like red dots on the forehead, on the base of the nose, and around the eyes, both upper and lower lids. So what this can be? We say it is red dot, pinpoint like. Of course, this is called petechiae. So petechiae in a newborn, what could be the cause in a newborn? It is due to knuckle cord, tight knuckle cord. That means the umbilical cord turn around the neck, making a pressure on the head and face, and this can happen in a precipitous delivery, or this was called unexpected rapid delivery, or a breech presentation. So this is the significance of these petechiae, which is normally and spontaneously resolved without treatment and disappear within the first few days after birth. It's important to distinguish it from infection related petechiae, that is to say due to thrombocytopenia. So in neonatal sepsis, if you remember, there will be thrombocytopenia, and this lead to petechiae. So if we give you a history, it will detect or determine the answer. But this is a petechiae due to birth injury with normal platelet count. What we can see in this slide, again we have to describe it. What we have here, this is a multiple of course this is a neonate, and this is part of his face and upper limbs, and this is the trunk, chest and abdomen. We can see here multiple irregular shape of red, purple color patches on the trunk and on the limbs, on the arm. So this is what's called ecchymosis and bruising. This is occur more with the traumatic and breech deliveries. This has a clinical significance, which is it may be associated with increased risk of hyperbilirubinemia, because this patches is a part of concealed hemorrhage or extravascular hemorrhage, and after hemolysis it will lead to development of neonatal jaundice. This can be happened more in preterm newborns than in term, and this may reflect blood loss when extensive in size and should prompt a search for occult sites of internal bleeding. But most of them resolve spontaneously within 1 week in simple cases. So not all of them lead to excessive blood loss. Again, this is ecchymosis and bruising and happen more in preterm babies. What we can see in this picture, again we have to describe. This is a neonate, and if you see here, this is called the CPAP. CPAP, which is a continuous positive airway pressure supplied for respiratory support for neonates with respiratory distress, whatever the cause, fixed on the base of the nose, then connected to a device of CPAP. So this means what? If the patient in this picture had a CPAP, this means the patient in respiratory distress. And if I can go to another part of the problem, I can expect found here the loose discoloration of the chest. So what this could be, and my patient is in respiratory distress, this could be due to excessive and extensive resuscitation by doing chest compression and cardiac massage, causing an induced or postnatal, during resuscitation, postnatal ecchymosis due to the pressure on the chest wall. So this is another example of a bruises. What we can see here, this face of a newborn baby. There is a bluish discoloration on the upper 2/3 of the face. So this is called face presentation. In cases of face presentation, that the face is the presenting part of the baby, and because of the high pressure on this area while the baby goes out the birth canal, so there will be ecchymosis and the bruising and distortion of the eyes, as you see here, because of excessive edema. But why this is not cyanosis? Because you see here the lower 1/3 of the face, its color is different from that. So this is a face plus the face distortion and edema due to the pressure. So this is a case of face presentation. This is another more clear example. You see here the difference between the upper 2/3 and the lower 1/3 of the face. Here color is normal and there is no cyanosis. Here is a pinkish lips, while the face here is blue because of the bruises, not due to cyanosis. And notice here the swelling on the eyes. This is another example of face presentation causing this bruises. Now we have to describe this slide. This is a back of baby, newborn. This is the head and this is the trunk. And we can see here, this is a simple slide because of the black arrows pointed to the problem. So what you see here, this is a hard and well circumscribed areas of erythema or of a blue color. This is called the subcutaneous fat necrosis. It's happened more commonly in term and post-term newborns. This is different. The pathology of this problem is different from the ecchymosis and the bruises that we say it is more in preterm babies. This is occurred because of focal pressure on and ischemia of to adipose tissue with the subcutaneous spaces during the birth process. Focal pressure and the adipose tissue between the baby and the ischial bones. So this will need more time for resolution spontaneously. This is may be 6 to 8 weeks, but it requires long-term follow-up, evaluation of development of hypercalcemia. because we say the problem here is a fat necrosis or subcutaneous fat necrosis, so after lysis or necrosis of these cells, there will be a liberation of their calcium content into the circulation, causing hypercalcemia. Subcutaneous fat necrosis. What is this slide? This is simple. Again, this is a newborn, and you see here this is the gentian violet dye, which is a type of disinfective liquids, and of course these is suture line, and these are the sutures. So this is what's called the laceration. Laceration can happen as a soft tissue injury during birth, and this can happen in products of cesarean section or vaginal delivery due to scalpel use. And the most common sites are the scalp, here on the scalp, or the gluteal region, or the thigh. Most commonly are mild laceration, and that are restricted to the skin, but sometimes it may need to be sutured, and it takes time to sutures to control the bleeding and to initiate the process of healing, as in this slide. Now we've finished the soft tissue injuries, and we are going to another group of birth injuries. I should tell you what I will do, not like what happened in the interactive session with your colleagues in the last or previous groups. So what we can see in this slide. This slide shows that there is a swelling on the scalp of the head of this newborn. And if you notice here, there is a depression. So what could be if there is a swelling and we can do a depression? Of course, the cause is edema. And because we are talking about the birth injuries and the newborn, it is called Succedaneum, which is a serosanguineous fluid collection above the periosteum, because most of the deliveries, the presenting part is the head presentation, and the vertex of the head, so because of the pressure, will lead to development of this edema. And this edema is above the periosteum, so it is not lined by the suture lines, and it is, as we say, soft tissue, and sometimes soft tissue swelling, but sometimes it may have a blue color because it may be associated with ecchymosis over the representing portion of the scalp. And as I say, it extends across the midline and across the suture line because it is above the periosteum, and this is occur at birth immediately, then disappear within the first few days of life. We can see with this type of birth injury the molding of the head and overriding of the parietal bones because of the excessive pressure on the skull bone, and this will resolve with time. What the management of the Succedaneum, it is rarely hemorrhagic and may need a blood transfusion if contain a huge amount of blood, but in most of the cases it resolves spontaneously without any intervention. The significance of Succedaneum is to differentiate it from other extracranial birth injuries. Now, this head of a neonate has an abnormality which is very clear, which is a swelling on one side of the scalp, and it is on the parietal bone and not across the midline of the head of this baby. So this is and the same color of the scalp. So this is a Soflo Hamartoma. And Soflo Hamartoma, by its definition, as you know, it is a subperiosteal blood collection caused by rupture of the vessels beneath the periosteum within the scalp, and it can happen in normal vaginal deliveries or in a cesarean section. Clinical features of it doesn't cross the suture line, not like the covered succedaneum, because it is subperiosteal bleeding, and it will lead to exaggeration of neonatal jaundice because the concealed hemorrhage or extravascular blood collection, this is hematoma from itself, so it will lead to development of jaundice. It's usually take time to appear, and because this is a blood collection, not immediately like the covered succedaneum, and the usual course, it resolves spontaneously within 3 to 4 weeks. This is a real picture from a patient visiting me, and if you can see here, this is a bilateral Soflo Hamartoma. How we can know this? Because we have two swelling on both sides of the scalp, but the midline is not swollen because this is subperiosteal bleeding cannot cross the suture line. This is clear from the side view, and I will give you another picture, make it more clear. Here is two projections on both sides, making the head of the shape of the head as a rectangular, because there is no swelling in this area midline because it cannot cross the suture line. This is Soflo Hamartoma. What we can see here, this is another type of extracranial birth injuries. This is called subdural hemorrhage. Here is the problem, is where is this site? Above the periosteum, not below the scalp, but above the periosteum, while this covered succedaneum within the scalp. So because it is above periosteum, so it again cannot be limited by suture line, and this makes the subdural hematoma is significant, although it is rare, but it is significant because it can readily result in sequestration of about 40% of more blood volume of the newborn, and 40% of a blood volume of a neonate will lead to what? Will lead to hemorrhagic shock, and it may lead to mortality if there is no intervention at the appropriate time. So the clinical feature of it may present as firm to fluctuant mass, because it is hematoma, that across the suture line, as we say, because it is above the periosteum, and this is typically noted within 4 hours of birth. This what mean? Rapid time of the happening, and the significance is the development of shock. So we should follow the patient in the classic triad of clinical finding, which is tachycardia, falling of hematocrit, decreasing PCV because of the blood loss, and increasing of OFC. It may be large and huge, involve all the scalp, causing increase in the OFC, and this can happen in the first 24 to 48 hours, and we should interfere at this appropriate time to prevent reaching to the shock state. This is the subdural hemorrhage. Now we will go to other part of the birth injury. We go from the extracranial, and as you see here, to the cranial injuries, and the arrow pointing to the problem, to the lesion, which is a linear skull fracture. Linear skull fracture usually is simple and affecting the parietal bone and need only close follow-up evaluation and monitoring. This may happen from the compression of the head by the use of forceps, or from skull pushing against the maternal symphysis or the ischial bone on bone, leading to fracture. But as I say, it is usually a simple and self-limiting problem. What we can see here, this is the head of a newborn, and here is the depression on the skull bone, again, which is the parietal bone. We call this a depressed skull fracture. Its incidence is rare, but it is significant. Why? We will know. The cause of this is the forceps delivery again, but because of the high pressure by forceps, it not lead to just a linear fracture, because depressed fracture. This means a complete piece of the skull bone separated from the surrounding and goes inward, pushing the brain tissue. So it may it may be simple and need nothing to do, just monitoring. This is if the fracture is less than 1 cm and there is no neurological deficit. But there is indication for surgical management, which is radiographic evidence of bone fragment in the cerebrum, to a presence of neurologic deficit, 3 signs of intracranial pressure increased, or signs of CSF cerebrospinal fluid beneath the galea, or failure to respond to close manipulation. Here we should refer to the neurosurgical department or neurosurgical consultation to interfere with. They will remove this part of the depressed bone fracture and to relieve the intracranial pressure or remove it from the brain tissue. So the question as example for this slide, it could be, what is the indication of surgical management of this problem? You have to know this is a depressed skull fracture, and you have to mention the causes or the indication of the surgical management. Now we go deep from the cranial to the intracranial injuries. And as you see here, I will give you example of the most common intracranial hemorrhage in term newborns, which is the subdural hemorrhage. You can see here, this is the subdural hemorrhage in the blue arrow, pressing on the brain tissue. And if you ask about the red arrow, it is beneath the scalp and above the periosteum. So this could be a subdural hematoma, but it is small in size and localized. The significance here is for the subdural hemorrhage. As we say, it is the most common intracranial hemorrhage in term newborns, and the treatment of it is accordingly. You have to go back to the lecture of birth injuries and to restudy it to remember the questions related to the birth injuries. But most of infants, as I say, can be closely observed without surgical interference, and the surgical evacuation is necessary for infants who exhibit signs of increased intracranial pressure. Go to other slide. Here, what you see here, what is the picture? Here is the MRI. Here is MRI showing the ventricles This is the lateral ventricles and filled with this hyperintense area because of the hemorrhage. So what we call this? This is called the intraventricular hemorrhage. And you have to know that, or I think you know, intracranial hemorrhage. It is intraventricular hemorrhage, sorry. It is more common in preterm babies and in traumatic deliveries, of course. This is maybe due to trauma itself, or due to perinatal asphyxia, or secondary to venous hemorrhagic infarction in the thalamus. And other questions, it will be accordingly. Now, I will go to other slide, which is here. This is again a newborn, and two abnormalities can be seen here. This is the redness in the cornea, in the whitish part of the eyes, as you see here, and the dot-like or pinpoint red dots. So the petechiae, and this is called the subconjunctival hemorrhage. Subconjunctival hemorrhage is a common problem. We can see it, and the cause here, again, it may be due to tight knuckle cord, pressure of the knuckle cord around the neck, causing the subcutaneous bleeding in form of petechiae and subconjunctival hemorrhage, as you see here. What happened with this infant? Because this is a 1 month baby, so this is after 2 days after the neonatal period. He is in the sleeping and looks well. So what was wrong with this baby is the tilting of his head toward the left side, and this is what is called the congenital muscular torticollis. Congenital muscular torticollis, it may be due to what? It may be shortening of the sternocleidomastoid muscle. This may be due to trauma, hematoma inside, or stretching of the muscle. This picture shows the congenital torticollis and its typical criteria. It's when the chin pointed away from the contracted muscle, and here is the contracted muscle due to stretching of its fibers or due to hematoma, and the head tilt toward the affected muscle. What about the course of congenital muscular torticollis? Most of the cases is resolved spontaneously and need just to do a massage for it. The massage for it to release the stretching of the muscle. How we can diagnose it? The abnormal presentation, the abnormal posture of the head and of the neck, and it is by palpation we can find a mass, and it is not discovered immediately after birth. It can discover in the first 6 to 8 weeks, and as we say, there is a mass which is firm spindle shape and located in the mid portion of the sternocleidomastoid muscle, and there is no inflammation or discoloration by the skin. And the treatment, gentle, as we say, gentle stretching to help relieve the tension, and surgery may be needed to correct the shortened muscle in special cases. What we can see here, this is a newborn baby crying, who is crying, and there is abnormality in his face while he is crying. The abnormality is a deviation of the his mouth toward the left side, and there is some difference between the closing of his eyes. So what is the cause of this problem? Of course, this is a facial palsy, but which side of the face is involved? This is a right side facial palsy, because as you know, the face will be deviated to the normal side. So the problem here is in the right side. Facial nerve palsy. What about the facial nerve palsy? You know the facial nerve palsy, it could be upper motor neuron and lower motor neuron, but in birth injuries it is of course of lower motor neuron because of the pressure on the facial nerve by forceps, by peripheral branches, and this is that's why involve both upper and lower part of the body, of the face, and this is usually resolved in 2 to 3 weeks, but sometimes it may be persist for a long time. So the clinical risk factor is the forceps delivery or prolonged second stage of labor, and the clinical manifestations, as you see here, there is weakness of both upper and lower facial muscle on the affected side, which is the right side, and this will lead to drooling of or dropping of the feeding of milk during feeding because of the weakness in the orbicularis oris muscle, and it may be associated with other neurologic findings, not just in the facial nerve. So the treatment is directed toward the protection of the involved eyes. We have to cover the eye on this side. You see here the difference between the eyes here and here. To cover the involved eyes by application of artificial tears and putting a pad on the eye to prevent the corneal injury. And if the baby may need neurosurgical repair of the nerve, should be considered only after the lack of resolution during the first year of life. So if it is long standing, but as we say, most of the cases resolve in 2 to 3 weeks. What we can see here in this slide. This is a newborn, and there is an NG tube in his right nostril, but this is not the cause why I show you this picture. You can see here the difference in the posture of both upper limb. What you can see here, this is an internal rotation of the shoulder and adduction, extension of the elbow, pronation of the forearm, and deflection of the hand. So this is called the Abduction palsy. Where is the problem in Abduction palsy? The question may be like that. So I show you this picture, and I don't ask you what is this. I ask you about the site of lesion. It could be that, like that. This is a brachial plexus injury, as you see, and this can be seen in traumatic deliveries, and the risk factor is macrosomia, big babies, shoulder dystocia, or difficult and instrumental deliveries, or even breech presentation. And then if we talk about the Abduction palsy, so the nerve root injured is the 5th and 6th cervical nerve injury, C5, C6, and this is the most common form of brachial palsy, brachial plexus palsy. And as I say, the arm put in the adduction, internal rotation, full extension of the elbow, pronation of the forearm, and deflection of the wrist and fingers, and this is called the waiter tip position. In those patients, the biceps reflex is absent. He cannot make a flexion of the elbow. Always flexed, no biceps. And moral reflex is absent. So when we do a moral reflex examination, inshallah I will show you how we do the neonatal reflexes. It will be a unilateral moral reflex because it is absent on the affected side. And I will go now to another slide. Here we can see this neonate. You can see here, oh, this is a clumsy palsy. Clumsy palsy, you can see here, there is a flexion of the wrists and the fingers, and there is a wasting of the intrinsic muscle of the hand if you compare it with the other hand. This is a clumsy palsy, and it involves the problem is in C8 and T1 nerve injuries, and this is lead to what? Lead to weakness, as I say, of intrinsic hand muscles and the long flexors of the wrist and fingers, while the biceps reflex is present, so the baby can do a flexion of the elbow, and it may be associated with hematoma of the sternocleidomastoid muscle and the fracture of the clavicle and humerus, and it may be associated with ipsilateral Horner syndrome that's presented by ptosis, meiosis, and enophthalmos, when there is accompanying of the injury in the sympathetic fiber via the nerve root T1, because you know nerve root T1 contains sympathetic and parasympathetic innervation. So if these involved can lead to what's called the ipsilateral Horner syndrome. Sometimes the problem is in total arm paralysis and involve all the nerve roots starting from the C5 to T1. This is called the total arm paralysis. Now, what is the management of the brachial plexus injuries, especially for the Duchenne palsy, Duchenne palsy? The management initially is to conservative, including pain management because this is painful, and holding the affected arm in comfortable position. This is called self-splinting. And once the diagnosis is made, the physical therapy should be started because this will lead to practicing and training of the muscles of the affected arm and prevent the disuse atrophy and prevent the contracture of the joints. And infant without recovery by 3 to 6 months of age may be considered for surgical explosion because this is depend on the type or the nature of the nerve injury. It is just the pressure on the nerve root, or it is a dissection of the nerve root itself, real crossing or injury to the nerve root. This affects the prognosis. Now we go to X-ray to show two X-rays. One of them is normal and the other. Who can guess? Yes, on this side is the normal and on this side is abnormal. If you see here, there is an elevation of the right dome of diaphragm in more than 2 intercostal space or in more than 2 ribs. This is because of a phrenic nerve injury, and this is arises from the 3rd and 5th cervical nerve roots injury, and it occurs most often with the breech deliveries and lateral extension of the neck. Injury to the phrenic nerve lead to paralysis of the ipsilateral diaphragm, and this is causing respiratory distress, recurrent episodes of apnea and cyanosis with diminished breath sounds on the affected side. And this bulging of the abdomen doesn't occur with inspiration. So this is how we diagnose it. Before 2 months, I was admit a patient, a newborn, that is with a phrenic nerve injury and pneumonia, and it was typical to see the paradoxic movement of the chest wall with the abdomen during inspiration, and the asymmetrical movement of the chest wall on the affected site of the phrenic nerve injury. And this, and the X-ray, it was typical like this. So what is the management of the phrenic nerve injury? I back to the this slide, because in a phrenic nerve injury, diagnosis chest radiograph, as we say, it's important, and sometimes we may do ultrasonography or fluoroscopy to see the movement of the paradoxic movement of the diaphragm during the inspiration, and the treatment is usually supportive with a close observation and hope of recovery within 30 days. But if there is no response on causing abnormalities in breathing, as we say, so the surgical plication or diaphragmatic pacing may be needed. That's mean they put pacing to enhance the movement of diaphragm during respiration, like what happened in this picture. So this X-ray is for the same baby, but this is after doing the surgical application of the diaphragm and return back to the normal anatomical position due to the accelerated function by putting a pacemaker. What we can see here, this is the long bone fracture. It is most frequently to see in the clavicle fracture, but here is the long bone fracture, which is the femur, shaft of the femur, and here there is a breech presentation or cesarean deliveries or low birth weight as a risk factor for development of this fracture. And of course the treatment is immobilization and splinting with the close reduction, and casting required only when the bones are displaced, and may need spica cast. Now we will go to another subject related to neonatology. This picture should be described. As you see here, there is a blue feet because of the bluish discoloration, peripheral cyanosis, that is common and a normal finding immediately after birth. And this is whitish material here covering the skin. This is called the vernix caseosa, which is a whitish greasy material covering the body of the newborn, and it starts to decrease while the baby is approaching the postterm. So this is making a lubrication of the baby between his body and the amniotic fluid, called vernix caseosa. This is a common finding seen in a newborn. It's seen in term babies and unlikely to see in postterm or in preterm. This is another picture showing a huge amount or excessive amount of vernix caseosa for a newly delivered newborn. What we can see here, this picture to show the difference between the color of the hand and the lip and the tongue. Here is pink, here is blue. So this is called the acrocyanosis or peripheral cyanosis, which is a common finding due to cold exposure or peripheral vasoconstriction, and it is not significant and resolved with time. Significant is when we have a central cyanosis. It could be of respiratory or cardiorespiratory causes or other than. And this picture shows the difference between the central cyanosis, all the body is blue, and the peripheral cyanosis, pinkish body and pinkish face and lips, while the peripheral cyanosis or bluish discoloration on just the feet and hands. This picture shows two siblings. They are twin. One of them is dusky color, earthy color, and the other is pale. One of them looks bigger than the other and buffy face. So this is called the twin-to-twin transfusion syndrome. And I think you know now who is the donor of his blood and who is the recipient. So this baby is dusky because of the polycythemia, and his brother is pale because of anemia. This picture again shows the difference in twin-to-twin transfusion syndrome. What we can see here, by the description of this slide, we see a generalized edema, swelling of all body, the face, the abdomen, and the limbs, and a huge abdominal distension. Actually, this is a stillborn baby, and this is to show the size of it, which is very small, because this is what is called Hydrops Fetalis. Do you know the causes of Hydrops Fetalis? Of course, you will answer that it is due to RH incompatibility or RH isoimmunization that is so severe to causing anemia and congestive heart failure while the patient is still in utero, and hepatosplenomegaly and ascites, and may lead to death. Yes, this is called the immune mediated. Firstly, the RH isoimmunization, or secondly, AB incompatibility can play a role. But we have what's called the non-immune mediated. Like what? Like torch infection that happened in, I will give you an example, like in parvovirus B19 as a cause of the torch infection for Hydrops Fetalis, and the other is congenital nephrotic syndrome, could cause it, or maybe SVT, supraventricular tachycardia for fetal supraventricular, causing a heart arrhythmia, causing a heart failure and anemia, and presented as Hydrops Fetalis. So put these causes in your mind to answer when you are questioned about the causes of Hydrops Fetalis, immune and non-immune. This picture from our neonatal care unit. This was my patient. Unfortunately, he dies after 2 days of this picture. You see here is in respiratory distress, severe respiratory distress, putting in the incubator, and here is the CPAP, and you see here is the huge abdominal distension because of ascites and hepatosplenomegaly, and this was actually a Hydrops Fetalis due to severe RH isoimmunization. Here is another picture to show the huge abdominal distension with hepatosplenomegaly. The same picture for the baby. Again, you can see here the abdominal distension, how it is huge. Now, what we can see in this slide, legs and feet, and of course there is a swelling of the feet, both feet, dorsal swelling, or this is called the pedal edema. So if I will say to you, this is a non-pitting edema, and this baby is female, you have to think this edema, if it's not pitting, because of lymphatic obstruction, and because I say it is female, you have to think the cause is Turner syndrome. What we can see in this picture, this is a fisted hand of a newborn, and there is a yellowish discoloration on a long lips with wrinkled skin. So these long nails indicate this is a post-term babies with wrinkled skin, and the yellowish discoloration, this is due to meconium staining that happened in term or post-term babies. The meconium staining can stain not just the nails, can stain the umbilical cord and the umbilical stem, making it in this green color. And it can involve all the body, the scalp, hair, and the of course the limbs and the umbilical cord. So as you see here, again the nail is long, a sign of post-maturity, and the wrinkled skin of the feet, another sign of post-maturity. So this is meconium staining, which is common in post-term. The significance of meconium staining is the meconium aspiration that may cause congenital pneumonia or meconium aspiration pneumonia. What we can see here, this is a bluish discoloration of the, well demarcated of course, of the back of the gluteal region and the thigh extending to the feet. Of course this is not ecchymosis or bruising, because it is homogeneous and well demarcated and involve all the skin. This is called the Mongolian blue spot, which is a normal birthmark, can be seen in babies, especially in dark skin. This is resolving with time. So these are called the normal birthmarks. What we can see here, we have to describe this abnormality seen here. This is called a reticulated or mesh-like appearance of the skin. This is or a marble-like appearance of the skin. And you know the meaning of marble. And this is this condition called the cutis marmorata. Cutis means the skin and marmorata meaning the marble. Al-Rokham in Arabic. This may happen, this may be a hereditary disorder called the cutis marmorata rubra, or it may be an acquired and transient because of the vascular instability, peripheral vascular instability causing vascular what we call it vascular constriction, leading to this shadow. Can happen in cold injury, in a prematurity, or in as a sign of sepsis. Cutis marmorata. Now what we can see here in the face of this newborn infant or young infant, here is the red color stain that cover the forehead, the upper eyelid, base of the nose, and in the area below the nose. This is normal birthmark called a salmon patches or nevus simplex or stork bite. Stork, if you know its meaning, it's mean luck in Arabic, and bite, so they think that the stork bite the babies from the their face and bring them to the families to give as a gift. And this is actually due to capillary distortion, epidermal capillary distortion. This with time will resolve. This is one type of capillary hemangioma, but is a simple. And this is in Arabic called al-wiham, or in our dialect tinsa. And this is the common site of it, and also at the back of the neck. Again, this is called salmon patches, nevus simplex, or the stork bite, nevus. And this is our stain. This is not significant, just a capillary, simple capillary hemangioma. But if you see here, this is a well demarcated red colored area, involve this part of the face, which is corresponding to the zygomatic tributaries of the trigeminal nerve. So it's going with the lines of dermatomes. This is called a port wine stain or nevus flammeus. This is due to capillary distortion. This is a more serious capillary hemangioma. It may be just a capillary hemangioma or capillary distortion, or it may involve with a CNS, serious CNS condition causing intracranial calcification and seizure, and in this condition it causes what's called Sturge-Weber syndrome, like this. So it is severe, involving the trigeminal nerve, and this is involved with microcephaly with intracranial calcification appear on the CT as a trauma tract appearance and with seizure. This is called the Sturge-Weber disease. Here is the abdomen of newborn, and you see here this irregular area of discoloration of hyperpigmentation. This is called the Caffi-Olea spots, and this is a normal birthmark if its number is less than 3 in faint skin newborn and less than 5 in dark skin newborn. But if its number is more than this, it may be a sign of a serious condition called neurofibromatosis. Caffi-Olea spots. What we can see here in this slide, you can see here this whitish papule, small papules on the nose and on the chin, on both sides of the mouth. This is called malaria, which is due to obstruction of the pilosebaceous gland or keratinization, called retention cysts found in the pilosebaceous gland. This is a simple birthmark and resolves spontaneously. While this lesion you see here, this is due to obstruction of the sweat gland. This is called malaria and can be seen in hot and wet weather, or that happened in areas of hot and wet weather. This is due to obstruction of the sweat gland. You can see here the back of this baby. This is the white papules with erythematous base. This is diffuse lesion found in the second day of life, and it may extend to from the second to the 7th day of life and may take time to resolve. This is a simple and benign condition called erythema toxicum. So its name is against its nature. It's not toxic. It is a benign condition, and if sometimes it may have not just papule, may have a vesicles, and if you take a sample of the vesicular fluid, it will be clear fluid contained just eosinophil. This is a self-limiting problem resolved without interference. We talk about malaria and say it is a retention keratin cyst on the pilosebaceous gland of the skin, and other form of it found here at the soft palate, at the junction of this hard and soft palate, at the roof of the mouth. This is called the Epstein pearl or retention keratin cyst, which is a normal finding in a newborn. When we do examination for them, we can see it. And finally, what you can see here, this newborn comes to me in the outpatient clinic, and I found him. He has these teeth. This is called decidual teeth, and since it's present since birth, so it's called natal teeth. It can be dislodged spontaneously, but the significance of it may be lead to suffocation or aspiration because of inward movement inside the pharynx and the larynx, or it may cause injuries and problems to the mother in breastfeeding. So if it is easily detached, it should be removed because it may be dislodged and leading to these problems. Now the first group of slides finished this time. I wish it was a good occasion to take information about this, and I will continue with you in next sessions in the coming days. Thank you for your listening.